Our network was involved with looking at the role of hospital stewardship programs, and in particular to look at whether we could provide some evidence on what works both within programs in hospitals, but of course what also works nationally and internationally, and in particular to look at whether taking a behavioural approach might actually provide additional insights on what can work internationally.
I know you have done deep and thorough research, but if you can summarize it a bit of your findings. I know that you have 3 different areas that you have looked into especially.
So the findings are actually relatively straightforward, but took a lot of work. So the first findings would say that antimicrobial stewardship in hospitals works. There are many studies globally. There are over 200 studies that have been conducted, and the evidence is quite clear. If you can put in good stewardship programs, they do work, and you'll get compliance with a person getting the right antibiotic at the right time. The problem is that what we know works. So things like providing a person with, providing a hospital or a person with feedback on what's actually happening in the hospital, who's been given an antibiotic, when they were given it, is very rarely put in place in hospital programs. So we have this mismatch between we know what works, but globally people are not doing or using the interventions within the programs within their own practice. And so our working group really has tried to illustrate this and then to demonstrate how individual countries, hospitals could go about implementing a stewardship program that might actually be successful.
What are the hurdles to actually make the implementations for the hospitals?
So there are 2 or 3 main things that are not put in place in stewardship programs, and the barriers, the common barriers that are mentioned in that context, they tend to be they don't have the available computer systems. They also don't believe that there is a consistent buy-in across all of the stakeholder groups. So by that I mean that that whilst your clinical or ICU might be interested in a particular stewardship program, they're not getting buy-in from the rest of the clinical colleagues or from the rest of the management team. This idea tends to be that because of these things, stewardship programs are not being implemented optimally.
Well, tell me, what is the funding from JPIAMR meant to this network?
So what we uniquely did with this network was the idea that, okay, we needed to match up what clinical microbiology and stewardship teams were doing with social scientists and implementation researchers. So what the funding enabled us to do was, from within each country, we were able to pair up, if you like, implementation researchers and specialists with the antimicrobial stewardship specialists. And by that we feel we've enabled this network to really put together that there are multiple lenses you can look at these problems with, but that there are known solutions in other areas, and by getting the groups together from transdisciplinary work, the funding has enabled us really, I think, to push on to the next sort of generation of studies and ideas to implementing stewardship programs.
How are you going to move forward with the results you made?
Okay, so we had a number of dissemination activities that were planned. We have obviously, from an academic perspective, done the academic papers, so there are academic papers going out reflecting many of the results. But we've also managed to incorporate the findings, the sort of the behavioural approach, into a massive online course, so a MOOC, which should be available towards the end of 2018. So people can just start to learn a little bit about the approach that we've used to understand better implementation.